When a serious emergency arises under anesthesia, there's no time to waste. Anything you may need should be kept ready for immediate use. These are essential in any operating theatre. A source of oxygen, a single cylinder if there's no anesthetic machine. The cylinder key must be securely attached so that time is not wasted in searching for it. There must be some means of delivering the oxygen to the patient, rubber tubing of adequate length, and a fine rubber catheter to pass down the nose into the nasopharynx. A glass funnel is very inefficient. In a dish reserved strictly for emergencies, there should be a sterile 2 cubic centimeter syringe and a needle. There should be a cardiac puncture needle. This is Hure's modification of Shipway's. Or another needle of 3½ inches or more in length. A lumbar puncture needle will do. Another container has ampoules of stimulant drugs: nicotinamide, ephedrine, lobeline, adrenaline 1 in 1,000, and an ampoule phial. Before starting any anesthetic, of course, you'll have a wooden wedge, a mouth gag, an artificial airway, a swab holder, and a bowl of swabs. Teach your assistants to do artificial respiration. There are many different methods of doing it. This is Sylvester's method. Hold the patient's arms at the wrists and draw them up, expanding his chest. Then bring them down to his sides and compress his chest. This is done slowly and regularly, about 15 times a minute. Alternatively, you can compress the chest directly. Expansion is passive due to the elasticity of the chest wall. This method is less efficient than Sylvester's, especially in a patient with laryngeal spasm where the chest is often already fully contracted. If you can't get air past the contracted vocal cords, you may have to use mouth-to-mouth insufflation. If there's an anesthetic apparatus, close the expiratory valve or tap, fill the bag with oxygen, hold the mask firmly on the patient's face, and turn the oxygen bypass tap at regular intervals. Lift the mask to release the pressure. Alternatively, you can keep up a steady flow of oxygen and force it in by compressing the rebreathing bag. When a patient stops breathing under an anesthetic and becomes cyanosed, she is in danger. You must get oxygen into her somehow. Feel her pulse. If it's strong and regular, you have a margin of time before her heart will stop. This safety margin varies with a number of factors. With the soundness of her heart, with the type of anesthetic used, chloroform, ethyl chloride, and to a lesser extent pentothal, depress the myocardium, and the heart will stop sooner in the presence of anoxia than it would with ether. It varies too with the amount of oxygen already present in her alveoli. If you're giving nitrous oxide with little oxygen, obviously that oxygen will very rapidly be used up, and the safety margin is by so much reduced. You must act immediately. First, lower the head of the table, if it can be done rapidly. This will assist the circulation to the brain. If there is obstruction due to a foreign body, vomit or blood, it must be cleared out. Turn her over to one side. This will allow the vomit to run into the cheek and nasopharynx. If you can't open her mouth, put a short rubber tube down the upper nostril. She may be able to breathe through this. If the obstruction continues, you will eventually be able to force her jaw open as the muscles weaken before death. Clear her throat at once. Insert an artificial airway and hold the jaw forward. Turn her onto her back before starting artificial respiration. Give oxygen or oxygen-carbon dioxide mixture. In this case, let in under a Schimmelbusch mask, not the ether-soaked one you've just used. An assistant feels the patient's pulse and reports at once any weakening or irregularity. If obstruction persists and the pulse begins to fail, pass the tube into the trachea through the mouth. Carry on with artificial respiration. If you can't introduce a tube, tracheotomy may be necessary, but this is very rarely so. Don't force oxygen directly down the tube. You may rupture her lungs if the pressure is too great. When the color improves, the emergency has passed, and you can wait a little to see if spontaneous breathing will start. But you must not let her become cyanosed again. When the heart stops, it's usually quite obvious. The color of the face turns to a pale gray, often blotchy. The pulse cannot be felt. The pupils are 3/4 dilated and do not react to light, and the intraocular tension drops. After primary cardiac failure, the breathing stops within a few seconds. If the circulation is not restored within 4 minutes, there may be permanent damage to the brain from anoxia, which often leads to death next 24 hours. You must have quite clear in your mind the procedure you would adopt, so that no time shall be wasted. The surgeon is warned to stand by. One assistant draws up 10 minims of 1 in 1,000 adrenaline in a syringe. Another feels for the pulse and watches the clock. Clear the airway and put in an endotracheal tube if you have one ready. Don't waste time looking for one. Start artificial respiration, preferably with oxygen. When the heart starts, the myocardium will have been weakened by anoxia, and it's important that the first few beats should drive fully oxygenated blood through the coronary arteries, or it may stop again. If the heart is not started, the auricle must be punctured with any available needle of 3½ inches or more in length. It should enter in the third right intercostal space, ½ an inch from the sternum, and passing inwards and towards the midline. If there's any response, it'll be immediate.